So today we have Shri Kant. I don't know if I said it. I hope I'm saying it correctly.
You got it.
Okay. And his Devarge. I messed that one up, didn't I?
No worries. It's Devraj.
Thank you. I should just have you do your own name. He is the co-chair for the Indiana State Epidemiology Outcomes Work Group. He earned his doctorate in economics from IUPUI in 2016 with fields in health economics and applied econometrics. He is also a research economist and research assistant professor for the Center of Business and Economy Research at Ball State University. His research focuses on public policy, health services, behavioral outcomes, regional economics, and business economics. Welcome. Thank you very much for joining us today. We really appreciate it.
Thank you for having me. I think it's always a pleasure speaking with groups who actually means a lot in improving public health. Thank you again. I'm assuming you all can see my screen. Okay, good. So I wanted to start off with like a brief background about what the State Epidemiological Outcomes Work Group is. We call that as SEOW or SEOW. So let me start off with that first. So this work group consists of we have representation from about 16 different state agencies like DMHA, Criminal Justice Institute, Department of Child Services, Department of Education, Department of Health, Indiana State Police, Department of Correction, high intensity drug trafficking areas, and even partnerships with IU's Prevention Insights as well. And we do have a group of individuals who are knowledgeable about mental, emotional, behavioral disorders, both in terms of prevention, intervention, and treatment as well. We act as an advisory capacity to the state of Indiana, DMHA, MAPAC. And the goal here is we identify, in fact, we try to monitor the substance use consequences and mental health and suicide in Indiana, and try to bring in these kind of evidence-based practices and data-driven practices in decision making. So this is like a brief background about our work group, what we do. So in the next few slides, I'll be showing you some of the prevalence or consequences for different substances in Indiana and some key takeaway points as well. And then with the intent of keeping the schedule today, I will not go over each and every bullet points here, but I will also highlight the important ones that actually would be worth taking a closer look at. So let me start off with alcohol. So all these data points we have collected based on whatever is currently available as of today, and which has been updated. And most of these data points there is always a lag in the data, and some of the data points that we collect here is from 2020. That means during the peak of the pandemic, we have data available during that time that allows us to see the pre-pandemic and during the pandemic, what happened during the prevalence and consequences of each of these substances. So in terms of alcohol, about 48% of users reportedly used alcohol or currently drink alcohol. It's a slight dip overall, a 1.1 percentage point. And if you see here, when I see users, I classify them as 12 plus years old. And the speculation being the slight drop that you see here is because of a lot of kids who were out of school at that time at home, that might be contributing to the reduction in the alcohol use. And when you're looking at the age distribution, 18 to 25-year-olds, we classify them as young adults. About 55% of them reportedly drink alcohol in the past month or current alcohol use. Now, this is a little bit higher than the national rate. So the national rate for overall was about 50%. For the 18 to 25-year-olds was about 52.9%. But in Indiana, it's slightly above the national rate for young adults. Now, coming to binge drinking, about 24% of users reportedly use binge drinking. It's like drinking more than 5 drinks on a same occasion. And on the right, you see a chart, and that shows the distribution of binge drinking by age groups. And you can see the 18 to 25-year-olds, young adults, they reportedly use, they indulge in binge drinking, are slightly higher than the national average. Now, coming to the adult alcohol use, so that story is a little different. So here we can see an increase of about 1.1 percentage point compared to 2019. There was an increase in adult alcohol use. It's contributing about 51.1% in 2020. When you break this data by gender, about 56% of men obviously consumed alcohol, but at the same time, what is surprising or something to note for is the women's adult alcohol use has gone up by 3.3 percentage point compared to the pre-pandemic area, so pre-pandemic year. So that's something that we need to kind of take a closer look at in the future, whether are they going back to the normals or not after the post-pandemic. Now, we also take a look at treatment admission. So these are some of the treatment episode data sets at admission. These are admissions to any substance use treatment facilities in Indiana. So there were about 24,000 admissions in state fiscal year 2021. And in those number of admissions, about 43% of them reported saying that they have used alcohol either as a primary, secondary, or tertiary substance in 2021. A slight uptick from the prior year. And 29% of them reportedly said they have used alcohol as a primary substance, and that's the reason why they are seeking treatment for that. In terms of the consequences, I think all of the data also relates that the age-adjusted alcohol attributable mortality has gone up. It's close to 13.7. That's the rate per 100,000 population. It's a 3.3 points jump from the prior year. And on the graph on the right shows it's kind of similar to the national average. Even nationwide, that number had gone up, alcohol attributable mortality. In terms of the collision rates, because during the pandemic, there was limited number of or reduced number of collisions in general. So the rates went down from 1 per 1,000 population to 0.61. And in terms of the child removals, and this is basically attributable to those parental abuse. Department of Child Services collects this data. In terms of the child removals, about 11.3% of those removals were attributable to parental alcohol abuse. So the key takeaways: adult alcohol use has gone up. Share of women consuming alcohol has gone up as well. Binge drinking still remains higher than the national average for young adults, and the alcohol attributable mortality has gone up too. So these are for the alcohol. Now coming to the tobacco. So 1 in 4 users reportedly used tobacco, and 1 in 5 used cigarettes, and 21% of men used tobacco, and 18% women smoked back in 2020. Sorry. A slight uptick in the women's tobacco use during the pandemic. And when you break this data down by different demographics, you would see higher incidence of smoking rates among working age population, 25 to 64, those with a high school graduate or less, and also those with among lower income groups too. And one other factor here is about the e-cigarette use. That has been an upcoming issue over the past 10 years, I would say. The youth e-cigarette use had gone up by 8 percentage points between 2016 to 2018. And now that we don't have data for 2020 because of the low sample size during the pandemic. But one key thing to look for is this increase of the drastic increase in vaping among high school students is a public policy concern. And coming to the college students, about 22% of them used electronic products or vapor products in 2021. So the key takeaway here is even though the adult smoking rates declined, but it's still above the national average. The national average is about 15.5. we are still at 19.4. However, smoking rates among women increased slightly during the pandemic, and e-cigarette use continues to be an issue and has to be monitored. And there are two policy things that I need you to kind of think through. One is there is this Tobacco 21 law that increases the legal age to buy any tobacco products from 18 years to 21 years. This law was effective from July of 2020. And effective June of this year, there is an e-cigarette tax that is in place as well. So now we need to kind of look this from a policy angle. Are these policies going to have any spillover effects of these tobacco products, especially among youth, to say smokeless tobaccos or to switching to other drugs? So that's a substitution effects, as they call in economics. So this is something that we need to be aware of. Next is the marijuana. About 11% users reported marijuana use in 2020. And always there has been a higher incidence of use among these young adults, 18 to 25. And on the right, you can see the trends going back all the way to 2008 in terms of the current marijuana use. And that rate has gone up since 2016, all the way to 26.7% for the 18 to 25-year-olds. So that has to be one of the data points that we need to kind of monitor. And among those treatment episode data sets at admissions, about 47% of them used marijuana either as a primary, secondary, or tertiary use. Now, and we have seeing this trends going up, we have included this as one of our strategic priorities. And there is one other policy perspective as well. So you have Illinois and Michigan. Where the recreational marijuana sales has become legal, especially in Illinois since 2020. And Michigan, I believe they were legal since 2018, but the sales started going up in 2019. So maybe from a local standpoint, are the border counties being more seeing some sort of an effect of increase in marijuana use or not? So these are some of the questions that we need to kind of think through. Sorry about that. Next comes the one of the other key issues on opioids. So we'll break this down into different data points. Let's first look at the prescription rates. What is happening with the prescription rates over time? And Indiana's rate is about 179.4 dispensations per 1,000 population. A slight decline so this is based on 2021 third quarter data, a slight decline from the prior year. However, when you look at the misuse in terms of prescription pain relievers, so these are like psychotherapeutic use with or without their own prescription, or using them on a greater amount not directed by a physician. So that rate is about 3.3% of users reportedly misusing the pain relievers. About 16% of treatment admissions, they have reported prescription opioids as like a primary, secondary, or tertiary use. And when I say prescription opioids, it has to be in general. It includes fentanyl, and that could be either prescribed or even illegally obtained as well. So and the next part is about heroin. Heroin, even though it's a tiny share of young adults, reportedly using heroin. But when you look at the treatment admissions, those who are seeking treatment these facilities, 23% of them used heroin either as a primary, secondary, or tertiary substance. So it is still one of the substance that we need to kind of look into as well, even though the overall incidence is lower. Now comes the consequences. So like, what is happening as a result of all of these is there were about 2,300 deaths overall due to drug poisoning in 2020. When you talk about the rate, it's about 36.6 per 100,000 population. And this is in general, any drug poisoning. And as of, like, I believe as of October 2021, there already had been about 2,500 deaths in 2021. It's surpassed the 2020 right in October. So I'm pretty sure October of 2021. So I'm pretty sure the next year, 2021 data is going to look even more drastic increase. Now, when you're focusing only on opioids, so that opioids, there were about, out of 2,316 deaths in 2020, about 1,875 deaths were involving opioids. And that rate, as you see, it's about 9 points increase. That rate has increased by 9 points compared to 2019. And if you see on the graph on the right, you can see the blue line represents any opioid overdose death rate. The orange line represents, we call it as a prescription opioid, but it's technically fentanyl, or that's either prescribed or illicitly made, and there are other substances involving opioids as well. So that is one of the major contributing factors of those rates. Now, we also look into ED visits, emergency visits due to opioid overdoses, especially during the pandemic. There were about 7,000 visits, 2,000 visits more than the prior year. So there has always been, even during the peak of the pandemic, there were emergency visits due to the opioid overdoses. So the key takeaway here is the deaths have been going up. And to give you a perspective, back in 2005, the age-adjusted rate of drug-induced death in Indiana was about 10.7 per 100,000 population. And the rates for US as a whole was 11.3 per 100,000 population. Fast forward 2020 to 2020, that rate is now like 37 per 100,000 population for Indiana, whereas the national rate is 29.5. So we surpassed the national rate over time in terms of these age-adjusted death rates by close to 8 points. That's the difference that we are looking at in terms of the magnitude related to the nation as a whole. And obviously, many reasons for these increases. Either it could be fentanyl use, either lower drug prices, or it could be polysubstance use as well. So I'll talk about that in a minute, like in the future, in a couple of slides later. It appears to be one of our key public health issues for Indiana. Now we'll talk about stimulants, cocaine and meth. As you can see, about 2% of users reported using cocaine. The national rate is about 1.9. Even among the treatment admissions, about 10% of treatment admissions, people reported using cocaine as a primary, secondary, or tertiary substance. When it comes to the meth, about close to 1% of users reported using meth, similar to the prior rates, statistically similar. Among treatment admissions, about 41% of them reported meth use, either as a primary, secondary, or tertiary substance. So this is one of the other key component here, where number of people seeking treatment, more proportion of them are being using meth. When it comes to the clandestine meth labs, sees that number have gone down drastically from it was like right now it stands at 38 lab seizures with about 39 arrests. And again, the key takeaway point is, the treatment admissions, if you look at those data points, people are using meth a lot. And the lab seizures have come down probably because of the effectiveness of these prescription drug monitoring programs and NPLEX systems in place for the over-the-counter drugs stops that happened during the pharmacy. So probably because of that, that number of seizures have probably come down. Now comes the polysubstance use. This is what I was trying to talk about. Like, what are people consuming multiple drugs, and how do we visualize this particular thing? So we try to use this treatment episodes. Like, these are people who are seeking treatment, and we are assuming this would be what is going to happen overall. We are seeing that about 35% of users who are receiving these treatment, or who are using opioids in this particular case, among them, they were using meth. So 50% of them who actually came to these treatment centers reporting opioid use, they also tend to use meth, followed by marijuana and alcohol. So these are the three key substances that opioid users tend to take along with apart from opioids. So now the question is this contributing to the death rates that we are looking at? And we do not know at this point what is contributing how much, either for overdoses, either to ER visits or to the death. So we are working closely with IDOH to kind of make sense what kind of polysubstance is actually causing it, and then maybe we can try some preventative action based on that. So this kind of a data set will be kind of monitored on an annual basis to see, to suggest some sort of like an evidence of polysubstance use. And now comes mental health. So we start off with any mental illness, which is defined as those with having a diagnosable mental, behavioral, emotional disorder. About 22% of users reportedly reportedly having any sort of mental illness, and about 7% of users reported having serious mental illness, a slight uptick compared to the pre-pandemic period. And those with one major depressive episodes, which could be explained as individual experiencing a depressive mood or loss of interest or pleasure in daily activities, and had a majority of the specified depression symptoms. So that number stayed about like close to 9% of users reported having either one of the major episodes the past year. And if you see the distribution on the right, I see that about 26 years and older in Indiana, they report slightly higher mental illness than the rest of the nation. So, and the remaining other groups are kind of statistically similar to the nation. Now, when you break this data down by gender and race, about 16% men reportedly had been told by a health physician or a medical professional that they had depression, and about 28% of women also were told that they had depression, a slight uptick during the pandemic time compared to the previous year. And when you break the data down by race groups, you can see across all age groups, there was incidents of depression increased. Particularly, the increases were pretty larger among African American race and Hispanic race. So those percentage increases were drastic. Now, there are multiple points to look for as well. It could be because there were a lot of increases in mental health services available during the pandemic time. So maybe some of the African American race or Hispanic race individuals may not have known that they had depression. They could have used the services, and that would have increased the rates as well. That might be why you're seeing those higher rates. So what would be good to see here is the next year, what is happening with these kind of race groups? Are we going to see a going back to normalcy kind of a thing, or are we going to still see higher rates? And then that would be a point of discussion at that point. Coming to the consequences, the suicide mortality rates slightly went up for Indiana. On the right, you see the blue line represents Indiana's suicide mortality rates, and the orange one represents the US rate. So there is a slight divergence between those two lines between during the pandemic compared to the prior year. So the key takeaway points here is the depression rates obviously has increased for both men and women, larger increases among Hispanic and African American races. And at this point, I also wanted to let you know, we are also monitoring some of the strategic behavioral health priorities for the next 5 years. And we have used, so over the past several years, we have been tracking the first 4 bullet points and see where we are and trying to set up the goals and see if we are meeting those goals. So I'll go over this really quick about what we are trying to see over the next 5 years, in addition to those data points I described. What is the tobacco use among youth and pregnant women? And for overall adults, we are trying to see if that, we're trying to see what's happening in those areas. Alcohol consumption among youth and young adults, prescription opioids and fatal overdoses, suicide attempts among youth and young adults. And we are adding a new priority this time, which is marijuana use among young adults. So this particular slide, it's kind of a little noisy, but it kind of details like what sort of measures are we looking at for these priorities, and what were the current statistics, and from where did we find them, and what is our SEOW goal for the next 5 years, whether or not are we going to match those goals, and what can be done to meet those particular goals. And this is in line with some of our work group recommendations, their agency recommendations and all. So as you can see, I won't be going over everything in detail, but I just want to give you some sort of an overview of what we are trying to look for. So in general, we also have certain recommendations that we are gonna work on. One is we would like to try and see improve our efforts on collecting data on indicators for priority population. When I say priority population, the state defines priority populations as college students, Native Americans, underserved high need geographic areas, rural areas, underserved racial and ethnic minorities like LGBTQ+. We also are going to monitor these overdose mortality data in detail in conjunction with Indiana Department of Health. Now that I also spoke about these Indiana Tobacco 21 laws and the e-cigarette taxes, we also would like to see what's happening with the e-cigarette use after those policies were in place. And also, are there any underage inspection data on tobacco retailers, whether or not the retailers are failing those inspections because of these particular laws? So that's something that we can look into and try to see if there is any other recommendations we can make. And then we are also going to look at, based on data availability, the mental health data preceding attempted suicide among youth. So these are like precursors for attempting suicide. So things like, are the students feeling sad or hopeless for 2+ weeks in a row, or they have considered attempting suicide or made a suicide plan? So these are some of the precursors for attempting suicide. So we are trying to see those data points as well. And so far, I have shown you some of these focus areas of our work group, which was alcohol, tobacco, marijuana, opioids, stimulants, and mental health. This year, we are going to add 2 more new focus areas to look for. One is on problem gambling and viral hepatitis, HIV, and AIDS. So as you may know, in problem gambling, sports betting was legalized in Indiana, I believe in 2019. And there are a lot of studies that talk about mental health issues or substance use issues associated with problem gambling as well. So we are going to try to take a look at that data point to we are working closely with the Department of Mental Health and Addiction to see if we can gather some data and see if there are any patterns or if there is any help needed in that particular front in terms of monitoring. And when it comes to viral hepatitis, we are looking for both viral hepatitis A, B, and C, and also on HIV/AIDS. So the reason being, they have a direct effect on the behavioral and mental health as well. So there are studies that talk about the co-occurrence of these kind of programs, such as effectiveness of syringe exchange programs that only 8 counties in Indiana actually has implemented them. So now the question is, are there any impact on behavioral health that we can kind of monitor? So these are some of the new areas that we are going to focus next. And to summarize, I just wanted to show you the website of some of the reports that we said. Probably, I think if you even type in Google SEOW FSSA, it should take you to this particular website. And there we have put all our prior past reports, and there are a few reports forthcoming, especially data points from my talk today. They're going to be there. A couple of projects that we worked on in the past year on alcohol use consequences. This is like regional trends data, mental health and suicide trends. They are already up in that website. And a couple of papers on COVID impact on behavioral health among overall population and youth. They are almost under finalized versions. They should be up pretty soon next week, hopefully. So feel free to use this website as a point of resource. And we also are going to bring in some sort of like a data portal so that people can go in and then view the data, see the charts, and explore them as well. So with that, I would like to conclude my talk. And once again, thank you for having me, and wanted to take this opportunity to thank you all for what you do collectively to improve the public health of Indiana. Thank you. And I'll be happy to answer any questions you may have.
Thank you. Does anyone have any questions that they'd like to ask?
I was kind of curious about the alcohol rates. So we did see an increase with adult use kind of across the board, which I think was expected with the pandemic and everything, but the mortality rates kind of increased at a greater rate.
So the data point that we use for, I think that's a great question. So I think, so on. So there are two things going on. So one is obviously the incidence has gone up. Now, how do we measure this alcohol attributable mortality rate? I think that's going to be the key thing, right? So the things that we use is based on CDC defined causes like alcohol abuse or dependence. It could be cardiomyopathy, polyneuropathy, or pancreatitis, gastritis, liver disease, poisoning, fetal alcohol syndrome. It could be everything. So we are not teasing it down by what is causing them, but we are trying to pool them together that could be attributable to alcohol. So that's where you see this now. There could be co-occurrence. Absolutely, I'm drinking alcohol and I'm also using other substances that is contributing to my death. And how am I putting in the statistic? Am I putting it under alcohol, or am I are they putting me under something else? So that also contributes some of these particular changes as well. But overall, what would be key thing is if you're comparing that with the nation, then that differences will kind of cancel out, because even are we higher than the nation, or are we going in the same direction as the nation? That's something that we can explore. Yeah, I think next year data is going to be a key personally for me to see, okay, now are we going back to the levels? So ideally, I should see a dip. Now that would strongly suggest that pandemic time, that behavior in alcohol had a major impact.
Any other questions? I know there was a, oh, go ahead.
Sorry, this is more logistical, but like we couldn't click on the link on the slides. So can those either be posted in the chat or just sent?
Oh, yeah.
Email? Thank you.
Yeah, I can put that right now in the chat.
Thank you for that. Great. Okay.
I have a question, and I know you didn't spend a lot of time on it, but I am thinking that fentanyl test strips are something that might be helpful in terms of preventing overdose deaths. Do you have a position on that? Law enforcement seems to be hesitant to do that.
Mm-hmm.
I know that I have a contact with the DEA, and I know he and I are going to talk about it, but and maybe I'm ahead of the curve on that, but it just seems to me like the risk of, encouraging somebody or enabling somebody would be well offset or more by, saving a lot, even one life from an overdose death. I think there was a case in Texas where it was a 16-year-old ordered oxycodone online and died from fentanyl. It's just getting to be a huge problem.
Yeah, I mean, I completely agree with you, Chuck. I think one of the key things I'm actually closely working on with this high intensity drug trafficking areas as well. It's like I have, and they are part of this our work group too. So I'm working closely with them to see, like, how is it? I mean, so from an economic standpoint, like if you look at it, if the drug prices are lower, so that means there is a supply thing going on which you cannot control. The supply could be coming from anywhere else. Either it could be illicitly made, it could be coming from, we have seen all these data points where they say a few doses of fentanyl is equivalent to that incidence is way higher than meth, or that similar dosage of meth or heroin or any other substances technically. So now the question here is, what are folks consuming along with fentanyl? I think, is that the killer right there, like polysubstance use, or they're having, say, marijuana, and they are also using fentanyl without knowing that they have fentanyl, and then is that triggering those deaths? So I think there is room for a lot of research identifying it, but I believe IDOH, what they do is, like, even with the ER data or overdose data, they have a way to identify whether or not fentanyl was available in as a again, the question is whether it's a primary one or primary diagnosis, or is a tertiary diagnosis that it's a secondary one, but at least we would be able to tease out that information from there. So I think there is room to I think it's still a public policy issue. I think I'm pretty sure once we have some data supporting those arguments, it's an easy way to kind of implement. Like I always say, like syringe exchange programs. I know whether or not it's effective or not, I have no idea. Can we test it out? Can we see if this data or evidence takes it? I mean, I'm just giving an example. So it's the same thing for here as well. Like once we are able to establish that evidence, then it's pretty easy for implementing even at a local level. So I think we should, this is like me talking, not ICOW, but I strongly feel we should do these kind of analysis and research and have that data-driven policies in place.
Thank you.
Sure.
Are there any other questions before we move on?
And I also wanted to let you know, this is like a blanket statement to everybody. I know you all are looking, I see you as like a grassroots level kind of a thing. And I did mention to Kimbra earlier, like if you come across any like thoughts or bottlenecks and things like that, feel free to reach out to me. I mean, I may not be able to give you a solution, but at least I'll be able to visualize what is going on in the grassroots level that's actually impacting. And maybe I can take that up through research. So I just want to keep that blanket statement to all.
Thank you very much. Next month's presenter will be CareSource, Brittany Bertaw and Jessica, we don't have her last name, about community learning collaboratives. So we're looking forward to having them come on. And then in August, Jamie Whitaker will be presenting on IRAC.